So if you're in the Democratic Republic of Congo, a stethoscope is actually a highly effective weapon of counterinsurgency.
Yeah, which sounds completely wild to say out loud.
Right, it sounds like a paradox. But today, we are doing a deep dive into a really comprehensive 2010 study. It was commissioned by the UK Cross-Government Group on Health and Conflict.
And it is a fascinating piece of source material.
It really is. And the mission for you, listening to this deep dive today, is to kind of unpack the deeply surprising, heavily layered, and frankly, really controversial ways that medicine is deployed globally.
Yeah, because we're looking at how healthcare is used not simply to, heal bodies. It's used to physically build states.
He win wars.
Exactly, to broker these incredibly fragile peace agreements in some of the most volatile environments on Earth.
So just think about that stethoscope for a second. To a physician in a stable environment, it is purely a tool for diagnosis, right? It's just medical equipment.
Just a normal day at the clinic.
Right. But you drop that exact same instrument into a conflict zone, and its function completely morphs. I mean, it becomes a diplomatic passport to cross front lines.
Or it becomes a tool used by a foreign military to extract intelligence from a village.
Yeah, or it acts as the foundational pillar of a brand new government that is just desperately trying to prove to its citizens that it actually deserves to hold power.
Right. Which brings us to the baseline. Because to properly contextualize what this study is actually analyzing, we have to establish the playing field,
Let's do it.
We need to define the difference between a fragile state and a resilient state, and we really need to move past basic high school civics to do it.
Okay, so give us the upgrade. What's the advanced definition?
So a resilient state operates on Max Weber's classic definition, right? It holds a monopoly on the legitimate use of physical force.
Right, the government is the only one allowed to have an army or a police force.
Exactly. But in the modern era, that definition has expanded a lot. A resilient state also holds a monopoly on the provision of systemic welfare.
Meaning healthcare.
Specifically healthcare, yes. A resilient state possesses deep organizational capacity, institutional memory, and like a rock-solid social compact with its people.
And a fragile state is just the absence of that.
More like a complete fracture of that compact. It lacks the institutional machinery to deliver basic survival services. Yeah. And while the general public usually visualizes international health interventions through this purely humanitarian lens...
impartial doctors flying in on white helicopters to triage the wounded.
Yeah, exactly. But the post-Cold War era, and intensely so after September 11th, it violently shifted that paradigm. Health interventions were openly transformed into strategic instruments of foreign policy.
Which is exactly why this source material is so crucial if you want to be, genuinely well-informed. Because if you want to decode how global foreign aid actually functions.
Or why you see news broadcasts of heavily armed Western militaries pouring concrete for medical clinics rather than just fortifying their own bases.
Right. You have to understand the underlying mechanics we are about to explore.
Absolutely.
But before we can understand how medicine can theoretically construct a state, we have to start by looking at the exact biological and infrastructural mechanisms of how conflict dismantles one.
Because the data in the study makes it incredibly clear. The kinetic violence, the bullets and the bombs, that is not the primary threat to human life in a war zone.
Which is wild to think about.
It is. The disparity is staggering when you look at the raw epidemiology. We naturally default to visualizing direct mortality.
Soldiers killed in action, civilians caught in a blast radius, that kind of thing.
Right. But modern warfare in fragile states is defined by what epidemiologists call indirect mortality.
Indirect mortality. Okay, unpack that for us.
This refers to deaths caused by the systemic collapse of survival infrastructure. So, primarily disease, starvation, and the loss of maternal and infant care.
Okay.
In the civil wars in Angola and Sudan, the data indicates that indirect mortality accounted for between 89% and 98% of the total fatalities.
Wait, I'm sorry, up to 98%?
Up to 98%.
That number requires a pause. Just let that sink in for a second. In a brutal, protracted civil war, the actual weapons of war only accounted for 2% of the deaths.
Exactly.
The environment that the war created killed the other 98%.
Yeah, the collapse of the environment is the real killer.
The study also points out that in the Democratic Republic of Congo, mortality rates in areas experiencing active conflict were 2 to 3 times higher than in relatively stable areas of the exact same country.
And this biological fallout, it's a historical constant. Though I will say the sheer scale in modern fragile states is totally unprecedented.
Right. The study actually draws a really fascinating historical parallel here to the First World War, didn't it?
It did, yeah. So between 1916 and 1917, the tuberculosis rate in Holland spiked by 50%.
Okay, but Holland was famously neutral during World War I.
Exactly. So the question is, why did a neutral nation suffer a massive infectious disease spike?
Right, they weren't fighting.
The mechanism wasn't combat. It was the secondary shockwaves of the conflict next door. Holland experienced this massive influx of Belgian refugees who were fleeing the German invasion.
Oh, wow. So just pure population displacement.
Yeah, and this sudden population density completely overwhelmed their municipal housing and sanitation. Combine that with severe wartime rationing of coal.
Oh, so people couldn't heat their homes.
Right, meaning people were living in freezing, damp, highly cramped indoor conditions, which is, the absolute perfect vector for aerosolized tuberculosis bacteria.
That makes so much sense. It's a domino effect.
Completely. And the study notes that a similar dynamic occurred during the Balkan Wars in the 1990s. The annual tuberculosis incidence in Bosnia literally quadrupled.
Quadrupled?
Yeah, because urban centers were besieged, water treatment facilities were destroyed, and people were forced into these subterranean shelters for months on end.
Okay, so we have this massive wave of indirect death. But how exactly does a modern conflict trigger this today? The study breaks the devastation down into 3 specific mechanisms, right?
Yeah, 3 mechanisms. The first one makes intuitive sense: direct morbidity and mortality.
Even if combat deaths only make up a small percentage of total fatalities, the sudden influx of catastrophic blast injuries, amputations, and severe burns, it instantaneously redlines whatever medical system is in place.
Exactly. The emergency rooms are just totally overwhelmed, meaning someone having a standard heart attack or complications during childbirth suddenly has a 0% chance of receiving care,
The system buckles under the initial surge.
which triggers the second, far more insidious mechanism, and that is the active corrosion of health services.
Right.
We are looking at a cascading failure here. Physical clinics are destroyed. The highly educated medical workforce, so doctors, nurses, technicians, they are usually the first to flee the country.
Because they can. They have the means and the transferable skills to become refugees in stable nations.
Precisely. Supply chains for essential medicines like insulin or antibiotics completely evaporate. And critically, the state diverts all remaining financial capital away from public health and directly into the military budget.
Just to ensure its own survival.
Exactly.
Okay, I have to jump in here because the phrasing corrosion of health services makes it sound so passive.
Yeah, it does sound a bit clinical.
Right, like the destruction of a hospital is just an unfortunate byproduct of 2 armies fighting nearby. It's collateral damage.
It's often very much not collateral damage.
Exactly. Reading the actual field reports in this study, it becomes horrifyingly clear that hospitals aren't just an accident. They're prioritized, deliberate targets.
Yeah, it's a specific strategy.
Think of it like a cyber attack on a major city's power grid. A hacker doesn't just turn off the lights to cause an inconvenience. They shut off the power to spoil the food in the commercial freezers, to disable the heating systems in the middle of winter, and to blind the emergency communications networks.
It's systemic dismantling.
Targeting a hospital isn't an accident. It is a calculated tactical maneuver designed to break the psychological and physical resilience of a society.
That is the grim operational reality of asymmetric warfare. Striking the health infrastructure is the absolute most efficient way to demonstrate that the central government cannot protect its people.
Which shatters the social contract we were talking about earlier.
Completely shatters it. And the examples cited in the study are devastating. During the civil war in Mozambique, Renamo insurgents didn't just casually damage clinics, they systematically destroyed over half of the primary healthcare network.
Over half.
Over 1,000 individual health centers, and they executed the medical staff.
That is, in El Salvador, the death squads took it to an even darker level of psychological warfare.
Oh, the El Salvador examples are brutal.
They literally carved letters into the flesh of murdered doctors and nurses and left them in public squares.
Yeah.
That isn't an act of combat. That is a broadcast message to the entire population that seeking or providing medical care is a capital offense against the insurgency.
It's pure terrorism. In Chechnya and Kosovo, the study notes that up to 80% of the health infrastructure was either destroyed or systematically stripped of all equipment by looting factions.
80%.
Yeah.
It just creates a total vacuum.
And that vacuum leads us to the third mechanism of devastation, the environmental and economic determinants of health.
Okay. What does that look like on the ground?
Well, when a population is displaced by the violence you just described, they don't just disappear. They aggregate in internally displaced person camps or spontaneous refugee settlements.
Right.
And instantly, basic hygiene and sanitation logistics collapse. Cholera, dysentery, and typhoid begin to spread through contaminated water sources.
Because you have thousands of people with no infrastructure.
Exactly. Agricultural cycles are disrupted because the farmers have fled, leading to acute malnutrition, which in turn compromises the immune systems of the entire population.
Making them vastly more susceptible to whatever infectious diseases are circulating.
Exactly. The devastation is total.
But it is not uniform. There's a specific sociological layer to this breakdown that the authors highlight, particularly regarding gender.
Yes, the gendered impact is massive.
The collapse of the state exposes women and girls to a completely different matrix of threats. The study details how conflict exponentially increases vulnerability to HIV and AIDS.
Yeah, the mechanisms for that are really disturbing.
You have the weaponization of sexual violence by armed groups, an explosion of forced prostitution driven by total economic desperation.
And the simultaneous destruction of the very clinics that could offer retroviral treatments or pre-exposure prophylaxis.
Right. The biological consequences of this specific violence, it echoes through the population for decades after the peace treaties are actually signed.
The baseline we've established is bleak, but it's entirely necessary. War fundamentally dismantles the biological safeguards of a nation.
But the central narrative of this deep dive pivots on a realization made by the international community in the early 2000s, right?
Yeah, planners looked at the sheer scale of this indirect mortality and asked a radical inverse question.
Which was, if the destruction of health accelerates war and state collapse, could the active provision of health accelerate peace?
It's an incredibly ambitious inversion.
It really is.
And it was triggered by a major shift in how diseases were classified globally. Because prior to the late 1990s, a virus was strictly the domain of the Ministry of Health, right? It was just a medical tragedy.
Right, it was a public health problem.
But then, specific diseases, primarily HIV, AIDS, and malaria, they began to cross a threshold. They were no longer just public health crises. They were officially recognized by intelligence agencies and military planners as systemic forces capable of destabilizing entire regions.
The data on this is striking. The International Crisis Group released reports warning that the HIV/AIDS epidemic was literally hollowing out African military institutions.
Hollowing them out.
Yeah, it wasn't just a matter of sick soldiers. The infection rates were so high that they were severely interfering with the deployment of international peacekeeping operations.
Oh, wow. Because a regional power couldn't project stability if a third of its armed forces were medically unfit to deploy.
And the civilian sector was hit just as hard. Look at the numbers from Botswana between 1999 and 2005. 17% of the entire healthcare workforce died of AIDS.
Yeah, the loss of human capital was staggering.
In South Africa, during a similar period, 21% of teachers between the ages of 25 and 34 died.
21% of young teachers.
When a state loses 1/5 of its young educators and a massive chunk of its medical professionals in half a decade, it is losing more than just people. It is losing the institutional memory, the bureaucratic functionality, and the literal operating system of the state.
And that systemic vulnerability, that's what fueled the rise of what policymakers termed the stabilization agenda.
Okay, the stabilization agenda.
Yeah. This framework really began to dominate foreign policy after the 2003 invasion of Iraq and during the prolonged reconstruction efforts in Afghanistan.
How does it differ from normal aid?
The stabilization agenda marks a massive departure from traditional neutral humanitarian aid. Traditional aid is governed by organizations like the International Committee of the Red Cross.
Right.
Its sole objective is to save a life today, regardless of who that person is or what side they fight for. Stabilization, however, is deeply political.
Okay, so what's its objective?
Its objective is to ensure a specific state structure survives tomorrow.
So how does the stabilization agenda actually operate? What are the mechanics of using aid to prop up a government?
Planners organized this agenda around 4 core pillars, known as the 4 Ps.
The 4 Ps.
Yeah. Interventions are designed to prevent violent conflict, protect people and crucial state institutions, promote political processes and governance, and prepare the ground for longer-term economic development.
Okay, let's drill down into that because the theory sounds very neat and tidy in a a London conference room.
Oh, on paper, it's perfect.
Right, but I want to know how that translates to the dirt. How exactly does delivering a crate of measles vaccines translate to promoting a political process?
It's a leap, for sure.
If I'm a villager in a contested province, why does receiving a shot suddenly make me loyal to a fragile central government instead of the local insurgent commander who lives down the road?
The mechanism connecting the vaccine to the loyalty is a concept called performance legitimacy.
Performance legitimacy.
Yeah, so if we return to our definition of a state lacking a social contract with its people performance legitimacy is the attempt to rapidly manufacture that contract.
I see.
The theory assumes that if a struggling central government, which is often backed by foreign donors, can successfully orchestrate the delivery of highly visible essential services, like opening a rural health clinic or executing a widespread vaccination drive, the local population will perceive that government as both responsive and capable.
So it's a transactional loyalty. We provided the clinic, therefore we are the legitimate authority.
Precisely. It sets up a contrast. If the insurgent forces are only extracting resources, demanding taxes, conscripting young men, and offering nothing but localized security,
And the central government is providing tangible biological benefits.
then the theory dictates that the population will naturally align with the provider of the services. The state builds legitimacy through performance.
And this theory that health could be weaponized for stability, it sparked a massive global initiative.
It really did.
Planners began looking for ways to use medicine to actively engineer peace agreements. The study dedicates a massive portion of its analysis to a framework literally called Health as a Bridge for Peace, or HBP.
Yeah, HBP.
They envisioned 3 specific structural bridges to cross from conflict to stability.
The HBP framework is a really fascinating attempt to leverage the perceived neutrality of the medical profession to achieve highly political, geopolitical ends.
So what are the 3 bridges?
The architects of this framework broke it down into 3 operational strands: prevention, peacemaking, and peace building.
Okay, let's start with prevention.
Let's look at the mechanics of the first strand, yeah. Prevention relies heavily on a specialized field known as conflict epidemiology.
Conflict epidemiology. How does that actually work in practice? It sounds like you're sending scientists into a war zone to run statistical regressions on violence.
That is essentially what it is, yeah.
Seriously?
Yeah. Traditionally, when refugees cross a border, doctors treat their immediate physical wounds. But conflict epidemiologists do something different.
What do they do?
They conduct highly structured retrospective mortality surveys. They interview the refugees to gather hard data on baseline death rates versus excess deaths, the specific types of violence witnessed, and the geographical origin of the attacks.
That's intense.
A pivotal example cited in the study is the use of these models on Sudanese refugees who had fled across the border into Chad.
Okay.
Epidemiologists from the CDC and other organizations didn't just compile a list of atrocities. They used the statistical data to mathematically diagnose that the mortality rates had crossed the specific threshold defining genocide.
So they translated human suffering into undeniable peer-reviewed data.
Exactly.
Why is that specific translation so important?
Because anecdotes of violence can be dismissed by politicians as the fog of war. Hard epidemiological data cannot.
Oh, I see.
The study notes that this specific mathematical diagnosis directly altered U.S. foreign policy. It forced the State Department's hand, legally and politically, shifting their stance toward the Sudanese government.
Because once you mathematically prove genocide, you're legally obligated to act in a certain way under international law.
Exactly. The health data acted as an early warning system and a really powerful advocacy tool to prevent further political paralysis.
That is the first bridge.
Yeah.
Data as advocacy.
Right.
The second strand is peacemaking. And structurally, this is the most cinematic concept in the entire study.
Wow, it really is. It sounds like a movie.
This is the implementation of temporary medically focused ceasefires. The working theory is that 2 warring factions might harbor deep generational hatred for each other, but neither commander wants their own children to be paralyzed by polio.
It hinges on the premise that a shared biological vulnerability can momentarily supersede a profound strategic hatred.
The flagship example analyzed in the text is the Days of Tranquility in El Salvador in 1985.
Yes.
You have a vicious, entrenched civil war. The logistics of this are just mind-bending. The UN and the Red Cross managed to negotiate with both the government forces and the guerrilla factions to completely halt combat operations.
Just an incredible feat of diplomacy.
Right. For a handful of days, the shooting actually stopped. And in that window, 20,000 health workers mobilized across the entire country, crossing heavily certified checkpoints, and managed to immunize 250,000 children against polio, diphtheria, and tetanus.
It is an incredible logistical and diplomatic triumph.
It's staggering. And it wasn't a one-off. The study details how this model was replicated in Afghanistan in 1994 for polio drops and in the Democratic Republic of Congo in 1999.
And the intention behind these negotiated pauses goes beyond just the immunizations.
Right, there's an ulterior motive.
The diplomatic hope was that by forcing these bitter enemies to communicate and establish a technical space where they coordinate on a purely medical logistical issue.
Like allowing a refrigerated truck of vaccines to cross a bridge.
Yeah, exactly. You create a micro foundation of trust. The theory is that this tiny sliver of cooperation can then be leveraged and expanded into broader macro-political peace negotiations.
Which brings us to the third strand, peace building. Assuming the conflict actually ends, how do you use the health sector to stitch a fractured society back together?
The study points to post-Civil War Mozambique as the prime case study for this mechanism.
Okay, what happened in Mozambique?
Following the peace accords, the national government faced the monumental task of reintegration. And they made a highly controversial, highly calculated decision regarding the health workers who had served the Renamo insurgency.
Remember, this is the same insurgency that had actively burned down government clinics and murdered state nurses.
Exactly. The government decided to officially absorb those insurgent medics and integrate them into the national, state-run health system.
Stop and think about the psychological reality of that workplace.
It's hard to imagine.
You have a government doctor assigned to a rural clinic, and they are forced to work a shift alongside the former rebel medic who might have been part of the unit that destroyed that very clinic a year prior.
Yeah.
It is a profound, forced reconciliation.
It is. The hospital ward becomes the crucible for national reconciliation. Because in a trauma bay, when a patient is bleeding out, ideological differences have to vanish immediately to ensure the survival of the patient.
So the health sector is utilized as the vanguard to model cooperation for the rest of the nation.
That's the theory, yes.
It is a beautiful narrative.
Yeah.
The data-driven advocacy, the enemies laying down their rifles for children, the doctors reconciling over the operating table.
That's very inspiring.
Well, we have to look at this critically. Did the health as a bridge for peace framework actually work? Did a 3-day pause for polio drops ever permanently stop a civil war?
This is where the authors of the 2010 study deliver a very cold, hard reality check.
Let's hear it.
They dedicate a significant portion of their analysis strictly to evaluating the empirical evidence behind these claims. Did the days of tranquility save hundreds of thousands of lives? Absolutely.
Huge public health win.
Yes. Did they successfully carve out temporary humanitarian space in the middle of active war zones? Yes. But the evidence suggesting that these medical ceasefires ever directly catalyzed a broader, lasting political peace settlement is exceptionally weak. The study characterizes the evidence as almost entirely anecdotal.
So the reality is that the warlords paused, allowed the children to get their oral vaccines, and then the very next morning, they picked up their rifles and went right back to slaughtering each other.
Essentially, yes.
The bridge didn't lead to peace. It just led to a healthier population of combatants and victims.
Unfortunately, the historical data strongly supports that conclusion. The warring parties agree to these medical ceasefires for highly cynical reasons.
Like what?
Well, a commander might agree to a 3-day pause because it gives his units time to reposition, to resupply ammunition, or simply to alleviate intense pressure from international donors.
It's a tactical timeout.
Exactly. It is not because the act of witnessing a vaccination somehow triggered a profound moral awakening and a desire for permanent peace.
And there is a much darker operational risk to this strategy. If you are a savvy insurgent commander and you realize that the international community, the UN, the major NGOs, are absolutely desperate to use health access as a wedge to initiate peace talks, what is your next logical move?
You weaponize their desperation.
Right.
You instrumentalize the health access.
Exactly. You turn the delivery of medicine into a hostage situation.
Yeah.
The commander tells the international envoys, I control the roads into this province. I will not let your cholera response teams to the checkpoints unless you grant my faction official political recognition.
Or unless you guarantee me a seat at the upcoming peace conference in Geneva.
By overtly linking healthcare to political objectives, the international community inadvertently hands the combatants a massive new bargaining chip.
And the civilians dying of cholera suffer even longer because their treatment is tied up in a geopolitical negotiation.
Which is precisely why traditional humanitarian organizations like Médecins Sans Frontières fiercely defend their absolute neutrality.
Yes, Doctors Without Borders. They refuse to be integrated into any political stabilization agenda.
Because they understand the mechanism of targeting.
Exactly. They know that the moment a local insurgency perceives a doctor not as an impartial healer, but as an agent of a foreign political agenda or a state-building project, that doctor loses their immunity.
They become a legitimate military target.
Right.
And that intense debate over neutrality, the danger of mixing the syringe with the state, it explodes into absolute controversy when the person holding the syringe isn't a civilian doctor from an NGO, but a heavily armed soldier in a foreign military uniform.
Yeah, this brings us to a major paradigm shift that accelerated in the early 2000s, the securitization of assistance.
The securitization of assistance.
This phenomenon occurs when combat military forces, prominently the US and UK militaries, during the occupations of Iraq and Afghanistan, bypass civilian agencies and begin directly providing health care to the local population.
We have all seen the visual propaganda. A heavily armored soldier kneeling in a dusty village, handing out blister packs of antibiotics to local children.
The military calls these operations MedCaps, Medical Civic Action Programs.
And the stated public rationale is always to win hearts and minds.
Always.
But the study digs deeply into the institutional machinery behind this and reveals that it is far more complex than just a public relations exercise. Why does the military actually want to play doctor?
The authors identify 6 distinct, often overlapping drivers that push modern militaries into the civilian healthcare space.
6 drivers.
It is a very tangled web of international law, tactical necessity, and really profound moral injury.
Let's break those 6 drivers down, because understanding the mechanism behind the MedCap completely changes how you view the entire concept of military aid. What is driver number 1?
The first driver is simply legal compliance.
Legal compliance.
Under international humanitarian law, specifically the Geneva Conventions, if a foreign military acts as an occupying power, they are legally obligated to ensure the basic public health and medical supply chain for the civilian population in that territory.
The classic you break it, you bought it rule of international conflict.
Pretty much.
Driver number 2 is the one everyone knows. Hearts and minds.
Yes, this is the core tactical doctrine. The theory dictates that if a military medic cures a local elder's chronic infection or treats a child's injury, that village will feel a debt of gratitude.
And crucially, they will repay that medical debt by providing actionable intelligence.
Exactly. Perhaps pointing out where an IED is buried or identifying the insurgents hiding in the valley. Medicine is explicitly traded for operational security and intelligence.
It's entirely transactional.
Completely.
Driver number 3 is fascinating because it zooms out from the tactical level to the grand strategic level. The study calls it mirroring enemies or competitors.
This driver is purely geopolitical. Western military planners recognized that their strategic competitors were utilizing medical diplomacy with devastating effectiveness. Consider Cuba. For decades, the Cuban government has exported thousands of highly trained doctors across Latin America and parts of Africa.
Right.
They embed in rural areas where the host government has failed, providing excellent care. In exchange, Cuba gains massive regional political influence and, famously, in the case of Venezuela, highly subsidized oil.
It's a strategic barter system, doctors for oil.
The study also notes China's deployment of the Peace Ark, a massive, purpose-built hospital ship that sails the Pacific and the coast of Africa, projecting immense soft power and building diplomatic leverage by treating thousands of civilians.
And it isn't just nation-states utilizing this tactic. Non-state actors and insurgencies do it incredibly well.
In many cases, they do it better than the states they are fighting.
Yeah.
The study takes a close look at Hezbollah in Lebanon. Hezbollah isn't just a militia. They operate a highly sophisticated social services wing. Following the 2006 conflict with Israel, before the Lebanese central government could even begin to organize a response, Hezbollah's construction and health wings were already embedded in the southern towns.
Oh, wow.
They were clearing rubble, handing out direct cash payments to families, and operating fully staffed clinics. By rapidly addressing the biological and economic needs of the population, they permanently cemented their legitimacy as the true authority in the region.
Completely sidelining the central state.
Exactly. The study even highlights how extremist offshoots, like Jamaat-e-Islami, deployed rapid response field hospitals following the catastrophic Kashmir earthquake.
They provided immediate trauma care.
And in the process, heavily recruited orphaned young men into their ranks. Western militaries looked at this landscape and realized they had to offer competing medical services simply to contest the battle space of public perception.
It's an arms race, but the ammunition is antibiotics.
That's exactly what it is.
Which leads us to driver number 4, spare military medical capacity. When a Tier 1 modern military deploys to a theater like Afghanistan, they don't just bring medics with trauma kits.
No, they construct massive, highly advanced field hospitals, places like Camp Bastion or Bagram, staffed by some of the best trauma surgeons in the world.
But here's the operational reality.
Right.
Thankfully, on most days, there isn't a mass casualty event involving their own troops.
Right.
So you have brilliant surgical teams and millions of dollars of diagnostic equipment sitting completely idle.
And the fundamental human impulse of those doctors, their core medical ethic, is to look outside the razor wire of their base at the local population who are suffering from horrific, entirely preventable diseases and say, we have the capacity, we have the skill, we must intervene.
Which plunges those very same well-intentioned doctors directly into driver number 5.
Yeah.
And this is the darkest, most agonizing section of the entire study.
Yeah.
It addresses the ethical nightmare of patient transfers.
It's incredibly bleak.
I want to walk through the exact mechanics of this dilemma. Imagine you are a military surgeon deployed at one of these pristine field hospitals. A local Afghan family approaches the gate carrying a child who has suffered severe burns from a cooking fire.
Okay.
You admit the child. You have the ventilators, the specialized burn units, the advanced skin grafts. You perform the surgery, and you save the child's life.
Incredible success.
But 2 weeks later, your unit gets orders to rotate out of the province. Or the child stabilizes, but requires 6 months of complex rehabilitation and infection control that your acute trauma hospital isn't designed to provide.
Right, because you're a combat trauma unit.
Exactly.
Yeah.
You now have to transfer this child to the local civilian Afghan hospital system, a system that might not have reliable electricity, let alone sterile bandages, specialized burn creams, or trained pediatric nurses.
The drop-off in care is staggering.
The secondary infection is almost a certainty. What does the military doctor do?
The study details how this exact scenario inflicts profound moral injury on military medical personnel.
I can't even imagine.
The disparity in care is so vast that the military doctors are sometimes forced into a horrifying triage calculus.
Like what?
They must weigh whether it is actually more humane to allow the child to have a pain-free, dignified passing with their family inside the military facility, rather than subjecting them to a complex, agonizing transfer to a doomed, under-resourced local clinic where they will suffer immensely before dying of sepsis.
Wow. The psychological toll of making that choice is staggering.
It is. And the study points out that the guilt generated by this disparity actively drives the military to use discretionary funds to hastily try and upgrade the local civilian clinics.
Oh, I see.
They buy generators and basic supplies, not as a grand state-building strategy, but simply so they have a moderately safe facility to transfer their patients into when they leave.
It is a reactive, desperate attempt to bridge an unbridgeable gap in capabilities.
Exactly.
And finally, we have the 6th driver, security sector reform. This is the realization by Western militaries that if their ultimate exit strategy relies on building a competent host nation army, like the Afghan National Army or the Iraqi security forces, they have to build a medical system for them.
Because local recruits will not volunteer to fight an entrenched insurgency if they know that a gunshot wound means a slow death.
Right, because their army has no medics or evacuation helicopters. So the foreign military becomes deeply entangled in building the host nation's military medical infrastructure.
6 intense drivers pushing the military to practice medicine.
Legal mandates, the tactical desire for intelligence, geopolitical mirroring of competitors, the ethical pull of spare capacity, the trauma of patient transfers, and the necessity of building a local army.
That's a lot.
It seems like an overwhelming, entirely logical justification for the military to be holding the syringe. But we have to return to the core analytical question of the deep dive.
Does it work?
Exactly. Does the MedCap actually work? Does a foreign soldier handing out medicine win hearts and minds and stabilize the region?
On this specific question, the study's evaluation is absolutely merciless.
Merciless.
The authors completely dismantle the hearts and minds doctrine. After reviewing the empirical data across multiple conflicts, they found zero credible evidence, none whatsoever, that military medical outreach programs generate long-term shifts in the political attitudes of the local population.
Wait. I have to push back on that heavily.
Go ahead.
If an American or British medic treats an Afghan elder's chronic pain or saves a villager's life with a course of strong antibiotics, how can there possibly be zero evidence of goodwill? Are the authors suggesting that human gratitude simply ceases to exist in a war zone?
No, of course there's gratitude in the moment.
Or is there a structural barrier blocking that gratitude from translating into political loyalty?
It is entirely a structural barrier rooted in the mechanics of how the military is forced to deliver that care. Let's look at the logistics of a medcap.
Okay.
Because of the constant threat of insurgent ambush, the military cannot announce a clinic in advance.
That makes sense tactically.
They roll into a village unannounced, set up a perimeter, pop a tent, and announce they will see patients for exactly 4 hours. They process hundreds of civilians in a frenzy, hand out blister packs of analgesics and antibiotics, pack up, and drive away before they can be targeted.
Meaning there is absolutely zero continuity of care.
Exactly. If a patient has a chronic condition like diabetes or hypertension, handing them a 2-week supply of pills and vanishing is medically useless.
Worse than useless, sometimes.
Furthermore, because these are rapid field deployments, the medics lack laboratory support. They cannot draw blood and run assays.
Right.
Consequently, the study highlights that military doctors frequently misdiagnose complex, localized tropical diseases like leishmaniasis or drug-resistant tuberculosis and prescribe entirely inappropriate medications.
And the villagers realize very quickly that the care is medically dubious. There is also a massive cultural disconnect. A highly trained combat trauma surgeon from London might be brilliant at repairing a shattered femur, but they're likely completely unequipped to navigate the deep cultural nuances of how a rural Iraqi elder describes psychosomatic trauma or chronic illness.
Exactly. The interaction often leaves the patient feeling profoundly misunderstood and disrespected.
But the most damning structural barrier to the medcap is the blowback.
Yes, the retaliation.
By accepting a packet of medicine from a foreign soldier, that civilian is instantly marked as a collaborator by the local insurgency.
And the military patrol leaves the village before sunset and returns to their fortified base. But the insurgent intelligence network remains embedded in the village permanently.
The study documents cases where patients were specifically hunted down, beaten, or executed by insurgents for the crime of accepting foreign medical help.
So far from winning loyalty, the medcap actively endangers the patient's life.
That is tragic.
Furthermore, when the foreign military rolls in with its high-tech gear and endless supplies, it casts a massive shadow over the struggling local Ministry of Health,
Making the host government look even more impotent by comparison.
actively undermining the very state the military is supposedly trying to build.
Let's zoom out and look at the massive administrative puzzle we've assembled here.
It's a mess.
The host nation government is functionally broken and too fragile to deliver healthcare. We've established that trying to use health access as a cynical bargaining chip for ceasefires fails to create lasting peace.
Right.
And we've just seen how having a foreign military attempt to deliver care to win hearts and minds is both medically flawed and strategically counterproductive.
Yes.
So we are left with a glaring void. Who is actually supposed to deliver the care to the millions of people suffering the indirect mortality of a conflict?
This void is what the authors term the agency question, and it represents the central defining paradox of the entire stabilization agenda.
The agency question.
Yeah, if your goal is twofold, to rapidly save lives today and to build a legitimate functioning state for tomorrow, you are trapped in a structural contradiction.
Let's unpack the mechanics of that contradiction. If you have an active cholera outbreak in a massive displacement camp, you need to save lives immediately.
You don't have time to wait.
You cannot wait for a corrupt, newly formed Ministry of Health to spend 6 months trying to figure out its payroll software and supply chain logistics.
Exactly.
So what does the international community do? They bypass the state completely. They bring in massive, highly efficient international NGOs, organizations like Oxfam, Save the Children, or massive for-profit logistical subcontractors.
Because these entities possess the operational capability to scale up rapidly, source the medicine globally, and deploy teams within days.
And operationally, it works. The study highlights the post-invasion reconstruction of Afghanistan as the ultimate case study in this model.
The international donor community and the nascent Afghan government sat down and debated the formulation of a BPHS.
What exactly is a BPHS? How is it formulated?
It stands for Basic Package of Health Services. It is essentially a standardized, rigorously negotiated contract. Donors have limited funds, so they must decide exactly what services are essential.
Okay, so making the hard choices.
Right. Will the rural clinics offer maternal care and vaccinations? Yes. Will they offer advanced oncology or long-term psychiatric care? No, it's too expensive.
Once this menu of services is finalized, the state realizes it cannot actually deliver it.
Right. So the donors massively subcontracted the entire implementation of the BPHS to international NGOs.
And if we look strictly at the public health metrics, it was an undeniable triumph, wasn't it?
Oh, absolutely. Within just 2 years of implementing the subcontracting model, these NGOs expanded rural healthcare coverage to 77% of the Afghan population.
That's incredible.
They established supply chains, built clinics, and undoubtedly prevented thousands of indirect deaths.
It sounds like a massive success story. But here is the structural trap. It's a trap I like to call the celebrity chef paradox.
The celebrity chef paradox. I like that.
Imagine you want to impress your spouse with a romantic dinner to strengthen your marriage. But you can't cook.
Okay.
So you hire a famous celebrity chef. The chef comes to your house, brings their own ingredients, wears your own branded uniform, cooks an incredible meal, and serves it directly to your spouse.
Okay. Sounds like a great night.
Your spouse is thrilled. The food is amazing.
Yeah.
But who are they going to thank?
Well, they're going to thank the chef.
Exactly.
Yeah.
They are going to thank the chef. Your marriage doesn't get stronger because you essentially paid for a date you didn't even participate in.
That is a perfect analogy.
This is exactly what is happening with the NGOs. If an international NGO builds the physical clinic, if the NGO logistics team flies in the vaccines, if the NGO pays the local doctors' salaries.
And they often poach the best talent away from the government because NGOs can pay higher wages.
Right, and the NGO's logo is plastered on the side of the ambulance. Why would a local villager feel any loyalty or social contract with the central government sitting hundreds of miles away in the capital?
They wouldn't.
Aren't we completely bypassing the state we are supposedly trying to construct?
You have articulated the exact paradox that haunts the stabilization agenda. Pervasive subcontracting risks rendering the host government completely irrelevant in the eyes of its own citizens.
How do they even try to solve this theoretically?
The theoretical model attempts to solve this by claiming the government is acting as a steward.
A steward.
The Ministry of Health isn't supposed to be hammering the nails into the clinic. They're supposed to be managing the contracts, defining the health policy, and actively monitoring the NGOs for quality control.
But the villager in the rural province doesn't see stewardship. They don't see a bureaucrat reviewing a contract. They see the NGO nurse delivering their baby.
Exactly. The visible performance legitimacy accrues entirely to the NGO. The social contract is forged between the citizen and the international charity, leaving the state out in the cold.
And this dynamic is massively exacerbated by the incentive structures of the international donors themselves, isn't it?
Oh, massively. The donor governments providing the billions in aid money are accountable to their own domestic taxpayers and election cycles.
Right.
Therefore, they demand quick wins. They want highly visible, photogenic results. They want to cut a ribbon on a shiny new hospital in the capital city or publish a press release boasting about 2 million vaccines delivered in a month.
Because it proves to their voters back home that the money is doing something tangible.
But state building isn't about shiny, photogenic hospitals.
Yeah.
True state resilience is built on funding the invisible, exceptionally boring bureaucratic plumbing that sustains a nation.
The boring plumbing. Give me an example.
It involves painstakingly building transparent procurement systems so that when the government buys medicine, the funds aren't embezzled.
Right.
It's about establishing reliable, refrigerated medical supply chains that don't get hijacked by local militias. It's about training an entire generation of civil servants to accurately track and analyze epidemiological data.
And international donors notoriously hate funding this invisible plumbing.
They hate it. It doesn't look good on a brochure. But without it, the moment the geopolitical winds shift and the NGO funding dries up, the entire facade of the health system collapses instantly.
Because the state never actually learned how to run it.
Exactly.
So after analyzing this incredibly dense web, the overwhelming wave of indirect mortality, the failure of military medcaps to win hearts and minds, the illusion of using vaccines as a bridge for peace, and the massive paradox of NGO delivery bypassing the state. What is the ultimate concluding doctrine of this 2010 study?
It's actually
Like, how should the international community actually approach health in a fragile state?
The study arrives at a conclusion that sounds shockingly simple, especially given the intense geopolitical maneuvering we have just unpacked. The authors advise that fundamentally, health must be delivered for health's sake.
For health's sake. After everything we've discussed, the strategies, the leverage, the state-building theories, that sounds almost naive.
It does.
It sounds like a retreat to the old humanitarian model.
It may sound naive on the surface, but it is actually a deeply pragmatic conclusion derived from hard operational data.
How so?
The evidence consistently demonstrates that the moment you attempt to instrumentalize a rural clinic, when you try to force it to act as a tool for counterinsurgency, or use it as a bargaining chip to force a warlord to the negotiating table, you inevitably compromise the quality of the medical care itself.
Because you're corrupting its primary purpose.
Right. You might build the clinic in a strategically important but demographically useless location. Or you might yank the medical teams out of a province the moment peace talks stall, using the withdrawal of care as a punishment.
And because you compromise the delivery of the medicine, you ultimately fail at achieving the political goal anyway.
The local population is incredibly perceptive. They know exactly when their biological needs are being used as leverage by a foreign power.
So the most effective way for healthcare to stabilize a fractured region is to completely decouple the syringe from the counterinsurgency manual.
Yeah.
Let the state build its legitimacy slowly, organically, by genuinely prioritizing the biological well-being of its citizens over decades, rather than relying on rapid-fire PR stunts funded by foreign militaries.
Precisely. If you want the medicine to work, both biologically and systemically, you have to separate it from the political agenda.
Wow. Let's pull all of these complex threads together.
Let's go.
We began by looking at the hidden, overwhelming toll of conflict, establishing the mechanism of how the collapse of infrastructure and the subsequent outbreak of disease kills vastly more people than the actual combat.
The 98% indirect mortality.
We explored how global powers recognized this vulnerability and attempted to transform health into a strategic weapon, a way to build bridges for peace or to win the hearts and minds of a hostile population.
And we learned that those grand strategies, while perhaps well-intentioned or strategically audacious, routinely shatter when they impact the harsh, complex realities of a fragile state.
The military's attempt to use medicine as a tactical tool lacks continuity, leads to misdiagnosis, and actively endangers patients.
And furthermore, relying entirely on the immense logistical power of international NGOs creates a celebrity chef paradox that actively undermines the legitimacy of the very government we are attempting to stabilize.
The ultimate takeaway from unpacking this source material is that while healthcare is an absolute, non-negotiable requirement for human survival, relying on it to magically repair deep, violently entrenched political fractures is a massive miscalculation.
You simply cannot cure a civil war with a vaccination drive.
And what this intricate analysis means for you, the listener, is a fundamental recalibration of how you interpret global events.
Next time you watch a news segment where a politician or a military general stands at a podium and talks about funding schools or building hospitals to stabilize a volatile region, you now possess the critical mechanical toolkit to see past the rhetoric.
You can look at the footage and ask the necessary questions. Is this intervention actually building the boring, invisible bureaucratic plumbing required for local capacity? Or is it just a highly visible short-term project designed for domestic consumption?
Who is actually holding the syringe in that village, and what exact political leverage do they want in return?
It completely changes the lens through which you view foreign aid. And I want to leave you with one final lingering thought to mull over today.
What is it?
Something that builds on the mechanics of this study, but pushes the implications just a bit further. Early in the text, the authors note that infant and maternal mortality rates are incredibly powerful, highly sensitive predictors of state failure.
Yeah, the data on that is extremely clear.
It operates like a mathematical canary in the coal mine. It makes you realize, long before the first angry protest erupts in a capital square, long before the first shot is fired by an insurgency, the absolute clearest signs of a collapsing society are already written in ink in the ledgers of rural health clinics.
That's a chilling thought.
The rising rate of dying mothers and children is the very first undeniable warning that the social contract is fundamentally broken. If health equity is the ultimate, most accurate early warning system for war, well, it begs the question, are we spending far too much time obsessing over the speeches of politicians and not nearly enough time analyzing the data collected by rural nurses?
It suggests that the true vital signs of a nation's political health aren't found in the parliament, but in the maternity ward.
Exactly. We have been looking at the wrong X-rays to diagnose the disease. Thank you for joining us on this deep dive into the source material. Keep questioning the headlines, keep hunting for the invisible systems that run the world, and keep asking the big questions.